Hello, everybody, and welcome to Arizona Telemedicine Program Webinar Series. I'm Melanie Escher, and I am the Distance Education and Event Coordinator with the Southwest Telehealth Resource Center and the Arizona Telemedicine Program. So we respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region, with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So welcome everybody from our Southwest Telehealth Resource Region, fellow HRSA grantees, and all of our other participants that have joined us today. So as you joined the webinar today, your phone or your computer mic was muted. We will be using the chat feature. So on the bottom of your screen, you'll see the chat. You can put your questions in there. This will be recorded and it'll be posted on our website later on today once it's been processed. So we do have a CME credit, and it's only available during the live presentation. There's a time limit on the code, and you'll be able to get that code in the evaluation. So the opinions expressed in the presentation are on the following slides, are solely those of the presenter, not necessarily those of the organization sponsoring the webinar. The organizations do not guarantee the accuracy or reliability of the information provided herein. That's why we always have to have our disclaimer. Here's the continuing medical education information, outcome objectives, the accreditation statement. This all went out on all your emails. I won't be reading through this. And we are using the attendance tracking code with the University of Arizona's continuing education department. That also went out in an email. And if you haven't set up your CAMS account yet, don't worry about it. At the end of today's session, all of you that are in attendance, I will send out another email with a little reminder along with the URL for the evaluation. You'll be able to get that code and text in your attendance. So again, please check our website for upcoming webinars and events when you're done. And that's pretty much where you registered for this as well. And so without any further ado, I get to introduce Tara Sklar. So Tara is, she's the faculty director of the Health Law and Policy Program at Arizona Law. And she also holds appointments as Associate Director for Telehealth Law and Policy with the Arizona Telemedicine Program and for Innovations in Healthy Aging with the University of Arizona Health Sciences. So she currently serves as a telehealth policy consultant with the Department of Health and Human Services, Health Resources and Service Administration in the Office for the Advancement of Telehealth. And she is coming to us live from her DC office. So without any further ado, I'm going to go ahead and stop sharing my screen here and she can get her screen set up.
Wonderful. Thank you, Melanie, for the great introduction, and welcome all of you. I'm so humbled by the number of folks that registered for this webinar and have joined us for the next hour. I'll go ahead and share my slides. Go.
There we go.
So perfect. Thank you. So as Melanie mentioned, I'm with the College of Law, but I also frequently head over to the Arizona Health Sciences side of campus with the College of Medicine and the Arizona Telemedicine Program, and then my work with the Innovations in Healthy Aging. I say all this because a good deal of my research and teaching stems around the adoption of telehealth among older adults. So you're going to see me touch upon that theme a bit in this talk, although the primary focus is on what's happening with the PHE at a federal level, and then a little bit of emphasis at the state. But before we get to all that, I don't have a disclaimer as much as a reminder. This is solely for educational purposes. It really is my goal over the next 45, 50 minutes or so, just to provide clarity on these issues and resources where you could go for more information. The slides are available. The recording will be posted on the link below. And I want to avoid being a data dump, but also provide you with where to go should you have further questions, and also just to help expose you to really exciting legislation at the federal and state level, as well as some studies in this area that you may or may not be familiar with. So I have broken this talk down into the federal level, of course, what's happening with the public health emergency and its impact on telehealth care and delivery. Also, quite a bit of time will be spent on virtual prescribing of controlled substances, given what's happening right now in this space with the DEA proposed rule. And relatedly, a lot more attention has been focused on the role that telehealth companies are playing in drug advertising for controlled substances. So I'll be touching on those together. And then at the state level, I'm going to highlight Arizona, just many of you on the call are from Arizona, as an example of what's happening, particularly with state licensure. But many states are following in similar ways that Arizona is doing. So I think it sets a nice example, even if you're not based here. And if you're not familiar with the Uniform Telehealth Act, I will explain what that is and how more and more states are looking at adopting that act going forward, which has interesting implications for telehealth, particularly with licensure. And then lastly, just looking ahead, there's some pretty exciting movements about the federal and state level on creating digital equity infrastructure to help better address the digital divide. So I'll end there with looking forward and what's happening at both the state and federal level. I also just from a kind of big picture overview of this space right now, it's a really, I think, an interesting and critical time because the PHE is coming to an end, and we're looking at, which of the flexibilities will be made permanent, especially after 2024. And the other thing that's happening is sort of this, from a regulatory oversight perspective, this sort of a Goldilocks approach, right? Where pre-pandemic, it was very limited and restrictive in terms of how telehealth was regulated and what that could look like going forward. And if there are some bad actors, as I'll talk about a bit with this drug advertising, how that has implications for how agencies such as the DEA and others, they begin to maybe over enforce telehealth again, or just finding that right amount, that Goldilocks approach between pre-pandemic and now going into post-pandemic. So I just think it's a very exciting time. And then at the state level, what states are doing in terms of trying to fill the void if there is not enough federal oversight, and then and some of the experimentation happening, but also on the flip side, trying to avoid a patchwork of options where like different states do different things. And that's where I'm going to spend some time talking about the Uniform Telehealth Act. Okay, so great, a lot of momentum here. Just so we're all clear about terminology and virtual care, telemedicine really has evolved from where it's been pre-pandemic to telehealth, which is including things like public health and healthcare administration, to all these digital health tools, with wearables and apps. So that is an area in digital health that I think we're going to see a lot more movement going forward, particularly with the patient's role in using some of these digital health tools. So for example, not only do you have, telehealth being, is it synchronous or asynchronous, but a lot of this remote monitoring, patients monitoring their own care, their own vital signs and biometric data through wearables and apps on their phone. And I think a newer trend that will become more prevalent is then providing sort of a two-way feedback where patients will not just have their vital signs passively collected, but also provide, reactions to how they're feeling, whether it's a new medication or how they're reacting to certain symptoms. So that will be a new way of going forward, how this whole area continues to evolve from a technology side, and then particularly with remote patient monitoring, especially in home health, which has big implications for those who would like to age in place. So that's kind of a picture of what's happening in the real world marketplace with virtual care. And now I want to talk about what happens on the legislative side in terms of how it's defined. And because it varies a lot among the states, and this has a lot of implications for reimbursement and access to care. So, and you can see it doesn't. This is Arizona's HB 2454, our telehealth bill, where it's very comprehensive in terms of listing every type of modality that's covered. And it has this audio only carve out where only if audio visual is not reasonably available. And just by comparison, you have Colorado, which is much more, it's more inclusive and broad, just saying any type of HIPAA compliant telecommunications is telehealth when it's delivered at a distance, but it does use that language, originating site to distance site. And then to compare these states with what's happening a little later in October of 2022 with this Uniform Telehealth Act, where the Uniform Telehealth Act, I should explain, is created by the Uniform Law Commission, which creates what they call model legislation, that they hope states will adopt so that we can have more consistent regulatory oversight in areas of the law. And this happens to be the Uniform Telehealth Act. It was just published in October of 2022, and it provides a definition that helps states will adopt. And you can see it gets even more broader in terms of potential technologies coming down the pipeline, with just any use of synchronous or asynchronous telecommunications. And it doesn't get into originating site language. It just says at a different physical location. So this is just a really fascinating evolution between, what's happening in the marketplace and then what is going on with legislation. So I wanted to tie those together for you because it has very important implications. Depending on how a telehealth is defined, how modalities are broken down can impact reimbursement. And then, as we know, reimbursement can impact access. So this is a way that the Center for Connected Health Policy broke down the Medicaid reimbursement by modality. And you can see it varies depending if it's a live video as opposed to audio only. And so this is going even more nuanced in the common reimbursement parity discussion. So coverage parity is when telehealth services are covered. Payment parity is when telehealth services are covered at the same amount as an in-person visit. So you can see that not only, even if you had, payment parity, if audio only is carved out and not considered part of telehealth, that can have implications for certain patient populations that can only access telehealth through their phone for a variety of reasons. So something to consider with how your state defines telehealth, and then also in the future at a federal level as well. I can flag it in Arizona. It's something that had a big impact on both with the modality in mind, audio only, and then what it meant for reimbursement. So as part of HB 2454, Arizona started a telehealth advisory best practices committee, and they were very thorough in terms of looking at best practices for telehealth care via audio only, and actually made a decision to reduce the number of codes that would be reimbursed from 94 down to in the 20s. And then after that, they amended that. So now it's currently based off what is happening with Medicare, but it has implications for how telehealth is broken down by modality and how that's defined in your state. So at the federal level, moving forward, or moving more broader, I just thought it important to cover definitions and terms and how they vary and then their implications on access to care. This is some of the key dates when it comes to the public health emergency. So many of you may be aware, we had the big budget bill that happened right after Christmas and before New Year's, the Consolidated Appropriations Act of 2023. That made some of the most important flexibilities in telehealth continue until 2024, such as being able to continue to use telehealth from someone's home, audio only, among others. And then right after that, the PHE ended by Health and Human Services. And so we are currently in in case you were counting, our 12th extension. For the longest time, we were in these 90-day incremental, like, will the PHE be extended or won't it? We were in that from the previous budget bill, this 151-day grace period. So the Consolidated Appropriations Act changes quite a bit of that to just say by the end of 2024, but also there are notable changes that are happening after midnight on May 11th when the PHE ends. So hopefully a succinct overview timeline there, given all the things that are happening in this space. I wrote a blog with the Arizona Telemedicine Program after the Consolidated Appropriations Act passed with sort of these 5 key takeaways. And really the biggest one is it moved telehealth away from these 90-day, moved telehealth away from the public health emergency. So no matter what happened, whether or not it was extended or ended, there was just a date, which is primarily is December 31st, 2024, of which a number of these flexibilities that I just referred to will be extended. The one I'd like to focus on for the moment is this, the in-person visits so basically here, under the Consolidated Appropriations Act, you could still have the waiver. We wouldn't have to have in-person visits to telebehavioral health. But as many of you may be aware, the in-person visit requirement for virtual prescribing of controlled substances is still tied to the PHE. So I'm going to spend quite a bit of time talking about that, but I do encourage you to check out this blog if you're still confused as to all the flexibilities that have been extended to 2024, because there are quite a few, and they all of which help expand care, all provide like a longer length of time for HHS to review and CMS to review if what's happening is which flexibilities will be made permanent is after 2024, looking at quality and safety, looking at cost efficiency. So on the virtual prescribing of controlled substances, we did a webinar during the public comment period with the DEA, with the Center for Telehealth and eHealth Law, and us, and it goes into a lot of detail about where we were pre-PHE, and then what happened during the PHE with virtual prescribing and what may happen now going forward. I will provide some highlights of it though, because I know it's quite a pressing issue. So we did our webinar in late March. There were about, I don't know, maybe 5,000 comments that had come in. By the end of March, over 35,000 comments have been submitted to the Drug Enforcement Administration about this proposed rule, which is prescribing an in-person visit for controlled substances, one in-person visit, in order to have virtual prescribing. This is a reaction to what happened during the PHE. The Ryan-Haight Act was suspended, which didn't require an in-person visit. And I'll go into more detail there. And then the other thing that's going to end on May 11th is, which I won't spend too much time on, but I wanted to flag it for you, is that the Office of Civil Rights Enforcement is going to no longer allow for HIPAA noncompliance, which was waived during the PHE. So things like connecting with your patients over Zoom or Skype or non-HIPAA compliant secure platforms will start to have much more oversight by the Office of Civil Rights. And if you click on this link that I have included here below, it's a press release from that office stating that there still is going to be a 90-day transition period, which takes you to August 9th. So if you're so as long as it does have a good faith clause, like in good faith trying to be HIPAA compliant, but they're not planning to enforce penalties until after that date. So that was a big shift come after midnight on May 11th, and then going back to what's happening with virtual prescribing. These were the exceptions during the Ryan-Haight Act. So if the DEA ends up not doing anything in this time period, and the public health emergency ends, the Ryan-Haight Act will come back. And these were the exceptions to not having to have an in-person visit under that act. And still be able to virtually prescribe controlled substances. So I'm not going to go through all of them. They're rather specific, but as you can see in red, during a public health emergency, that was an exception to having an in-person visit. And then this idea of a special telemedicine pathway. And what's interesting about the Ryan-Haight Act is this was enacted in 2008. And then 10 years later, in 2018, there was another legislative act signed into law by President Trump saying that there should be a special telemedicine pathway that allows for providers to virtually prescribe controlled substances without an in-person visit, and requiring the DEA to create that pathway. The DEA declined to do so, and also has declined to include in this proposed rule a special telemedicine pathway. And the reasoning is saying it's too burdensome for providers and patients. But I want to flag it for you because it's mismatch between what's happening in Congress and this particular agency. What the DEA is proposing in this rule that received over 35,000 comments is there should be a referral pathway, which I'll explain in just a minute, and that also anyone who provides a virtual prescription for controlled substances must have a DEA registration, both in the state where the provider is located and then also where the patient is. And then the other big takeaway from this is the 180-day waiver. Basically, after May 11th, there's about 6 months where patients that have an established relationship with their provider can continue to receive virtual prescriptions of controlled substances, but that will end after that period. The qualifying telemedicine referral is where another provider meets with the patient in person and then can provide a referral to the prescribing telehealth practitioner so that they can continue to prescribe virtual prescribing of controlled substances. So that essentially is what it is. That could still create all kinds of issues, but that's one way that the DEA has moved forward in the Ryan-Haight Act. The DEA has also produced a number of materials regarding their proposed rule. Specifically, this is just regarding controlled substances, not things like antibiotic or non-controlled drugs, and that it treats Schedule II drugs differently from Schedule III through V, where a 30-day refill could be prescribed virtually even after this proposed rule, if it goes into effect after the public health emergency. The DEA also produced this graph, which for those that are still trying to come to terms with what exactly is happening with this new rule of when you have to have an in-person visit and when you don't. So in order to virtually prescribe controlled substances, and so essentially if they meet in person once, then you can. If you do it through a telemedicine referral pathway, then you can continue to virtually prescribe. You get this 30-day refill, and then it's quite specific that with Schedule II, if it's an established relationship, you have that 6-month window. But if it's a new patient relationship, then you're going to have to meet in person to set up that virtual prescribing of controlled substances. So what happens now? So now the DEA has 41 days since they received 35,000 plus comments to review every single comment. They're required to review every one and kind of categorize them and then respond to them in the Federal Register to justify why it is they went with their decision. They have to say their approach accomplishes the goals of the problems identified. They're particularly looking at preventing diversion or abuse, and also they consider the alternative solutions. So the DEA can decide to modify their proposed rules based off all the comments received, or they can decide to just not go forward with it at all, or go forward with it exactly how it's proposed. So more on that to come, but that's where we currently are at this moment in time. Hopefully that they'll see that there is a general just mismatch between what they're trying to do and the proposed rules. Having this blanket one-off visit, what that could do to continuity of care. And also if there are all these effective oversight already in place. So I've spoken on this before, and I think it's important to mention that, because even after if this proposed rule does go into effect the way it's written, there's still safeguards that you can do as a provider to help prevent diversion and abuses of controlled substances. So certain business practices, compliance with state law, and just other approaches that don't impact limiting access to care the way that this requirement could. And then, of course, anytime there's data showing that over the past 3 years, what has your clinic or your practice seen is very, very helpful in persuading agencies one way or another with what they're deciding in terms of regulatory oversight. It's also always important to focus on particular populations. Certainly, like an in-person visit could harm those who are on Medicaid, could have limited availability with their work schedules or with other demands and limited means to go to an in-person visit. And then I listed a number of other particular population groups where this rule could be particularly harmful and also counter to what's happening at the federal level. There's been so much effort by the Veterans Health Administration and the Biden administration to address behavioral health with vets. And so it's notable that this applies to them as well. There's been an incredible surge of articles all about this issue, particularly in behavioral health, a really fantastic piece in Health Affairs. DEA telehealth proposal brings risks, not patient protections. And there's also this kind of new reality with virtual care options where choosing your provider should not simply be determined by proximity. And then particularly with behavioral health and psychiatry, there's a number of other factors to consider that could be more important to quality and safety of care than just where you happen to be located. So just to wrap up the whole piece on virtual prescribing of controlled substances, it's a big piece to say this is just simply not feasible to have an in-person requirement, given that half of US counties have 0 psychiatrists. And then the extreme short notice, both for the DEA to monitor and enforce this and for business practices to adapt, particularly for new patients after they've been, had this flexibility for the past 3 years. So one thing that I think might be quite probable is, potentially just extending the flexibility, at least for existing relationships, to the end of 2024, and that would align it with the Consolidated Appropriations Act of 2023. But we'll have to wait and see what happens. I'm also optimistic that there could be some movement, and I give a number of examples in the next few slides regarding audio only. As I mentioned with Arizona, at the federal level, audio only continues to have a lot of scrutiny. So the Office of Inspector General did a great study looking at this, and they identified that for Medicare beneficiaries, 1 in 5 use audio only, and 93% of them nearly exclusively. So to not include audio only as a part of reimbursement for Medicare could have a huge impact on a certain population. And I think that had some sway along with these other studies in terms of how audio only continued to get included going forward to the end of 2024. Another is just the from a race ethnicity perspective, who tends to use audio only services. And this graph from ASPE, the Assistant Secretary for Planning and Evaluation, if those with a white background tend to use more synchronous live video audio, whereas those who are Latino were more like the highest number to use audio only. And then this report goes into even further detail, looking at video audio in comparison to audio only, looking at other socio-demographics like income, education, and age. So also very persuasive to show the disproportionate impact to not allow the audio only modality to receive Medicare reimbursement. And then lastly, this is looking specifically at behavioral health and the direction it's going. And it's pretty astounding that over 44 states do allow audio only coverage for behavioral health. And that's much, it just shows the need to allow the options and flexible modality for patients to be able to receive care, and the direction that the country seems to be going forward, and then the impact that could have on what rules become permanent after 2024. So just a few final things with the DEA proposed rule, if it does go into effect, what you could potentially do now. And so your DEA registration for patients that are in different states to get your registration number for that state, to create a new business plan scheduling that allows for an in-person visit if that's currently not how your practice is set up. This DEA proposed rule, I think, in many ways has the biggest implications for new patients, because suddenly telehealth more and more has been, you can set up a a provider-patient relationship if via telehealth. But this DEA proposed rule in new patients, that's limited in some ways because you can still have that relationship, but you can't virtually prescribe medications that are controlled substances until you meet in person. So in some ways, it undermines where we've come so far with recognizing telehealth and setting up that provider-patient relationship, which I think is important to note. And then there's just a variety of ways to play with the qualifying telemedicine referral. Some say do this hybrid option where the telemedicine provider is connecting into the appointment with the in-person one, and then of course to inform patients. And that's really the biggest piece. Is like, this is not something that is quite. It's still very unclear. The DEA really hasn't promoted what they're doing so much, partially due to the short timeline, and they aren't like HHS or CMS is used to creating these massive press releases of like how things may change in terms of care delivery. So it's upon us to educate our patients and colleagues and depending on what happens. And then the other piece that I think is interesting to watch is there might be congressional pushback. Certainly there's already been folks who are speaking out about this. And I don't think nothing is ever done. So even if this proposed rule goes into effect, those safeguards I mentioned and data will be very important. So, but I want to flag like how the DEA got involved with that particular decision to require an in-person visit and what this means for preventing potential abuses. And I do think that how some telehealth companies have been investing in drug advertising for controlled substances triggered some of this. So this has been in the news more and more lately. This is a great piece in the Wall Street Journal. And just the number of telehealth companies that are advertising controlled substances has swelled, and there's no reason to think that it will be reduced anytime in the near future. And what is interesting from a regulatory perspective is they don't really have oversight in this area. So in some ways, this is a quote from the president of the AMA, direct-to-consumer advertising is just controversial in general. To start with the treatment instead of the problem, I thought was really, really well put. America is quite unique in that we even have direct-to-consumer drug advertising. This is traditionally regulated by the FDA. However, the FDA only regulates drug manufacturers and distributors. And that's where you see all those advertisements for drugs. They're so prevalent, where you always have the fine print at the bottom. It'll say these are actors, not real patients. The information has to be presented as balanced, where you show the benefits and the use, along with the side effects and risk, and also what the FDA has actually approved the drug for. So just to flag that for you as you're thinking about what these telehealth companies are doing and where oversight fits. So that's what the FDA has the authority to do. The other major agency in this area is the Federal Trade Commission, the FTC, and they can take down ads and investigate if the ad is misleading, but that is not that can easily be skirted as opposed to these specific requirements that the FDA has where you have to disclose risk information. So what happens, and this is an ad, there's so many of these now, but this is a company that's advertising ketamine, and it's not exactly misleading. It's pretty vague. What's interesting is you'll note that the actor in each one, Heather, clearly is not a patient, or it's a woman of different ethnicities, and there's no listing of side effects or potential contraindications. It's still a controlled substance. So the telehealth companies are arguing, especially that's under investigation, that they just facilitate interactions. They're not part of the prescription process, but this is not an area where there is oversight. And you could see how this federal regulatory patchwork approach, where the DEA flagged that there was a huge spike in Adderall use among middle-aged women. And like, where did that come from? And you could see that probably some of them came from these advertisements from telehealth companies showing here's how you can focus more and be more productive. And there's not any oversight there. So I just want to flag that for you as an area where there's an interesting gap, and what that can mean, where we have meaningful, effective regulatory oversight, both for these telehealth companies and the drug advertising space, and then also for virtual prescribing of controlled substances that really are needed. Okay, so moving on to what's happening at the state. I know a number of you on this call today are not from Arizona, but I want to flag for you the Center for Connected Health Policy, because they produce these great at-a-glance fact sheets for your state that break down all of the relevant telehealth regulations, law, and policy in your jurisdiction. So if you haven't looked at that before, it's a fantastic resource. And I'll just focus a bit more in Arizona to say some examples of what we're seeing at the state level right now coming out of the public health emergency. One thing I want to mention, and different states handle this differently in terms of virtual prescribing of controlled substances, but here in Arizona, you are able to have an audiovisual examination count as a visit to do virtual prescribing. So if the DEA proposed rule goes into effect, that would effectively require an in-person visit, and federal law precedes state law in this area. What's also interesting about Arizona, and other states are doing this too, is actually because there's such a need for behavioral health that they've tried to expand what psychologists can do in this area, and permit certain psychologists to be able to prescribe medications. This proposed bill has been withdrawn at the end of March, but it was novel as a way to expand access to care that actually made the National Law Review. So I thought I'd flag it for you, and I think it is not unreasonable to expect more states looking at ways to create this expansion of prescribing options going forward for other providers. The other pending legislation, recent and pending legislation in Arizona, again stems around this idea of continuing to expand telehealth as the public health emergency ends. It's made it clear recently that you can establish telehealth, establish a doctor-patient relationship through telehealth as it's defined. And I shared that definition with you at the very beginning in the state law. And and continuing to expand to different types of providers, including veterinarians, other services such as medical marijuana certification. And then, and this is happening all throughout the states, this idea of compacts when it comes to licensure. So I heard a great phrase the other day referring to compacts around all these different compacts that are happening around the country, that we're entering the compact nation, because so many providers would like to be able to provide care across state lines as they've been able to do during the public health emergency. So these are all the currently active compacts. As an example, the ones that are highlighted are the ones that Arizona has enacted or has introduced. And there's just incredible movement here. So basically, these are compacts where there's language that 2 or more states have agreed upon, 7 or more states have enacted, that recognizes the credentials that are needed for a provider with these different disciplines to be able to provide care in a different state through this more streamlined process. And a lot of states have enacted these. The Interstate Medical Licensure Compact is now at 38 states. The nurse licensure is at 39 states. I think physical therapy is at 25 states. And then the big news that I heard just recently from a colleague, Chris Stewart, is for the longest time, New York, the larger states, New York, California, didn't want to be part of compacts. They didn't feel a need, the providers, to have more out-of-state providers come in. But New York has now proposed that all 8 compacts be introduced in New York. So that's a huge change from where we previously were. And as you can see, there's more compacts in development. So as there's basically silence in terms of how, from a federal level, in terms of how to allow interstate practice with licensure, these compacts are becoming increasingly prevalent. The other pathway to licensure that more and more states are adopting is, rather than a full license for out-of-state providers to practice in the state, this idea of a telehealth registration, which we do have here in Arizona. A number of other states also have a similar process for, but basically, if you're in good standing in another state, rather than going through the full licensure process, you can apply for telehealth registration, and there are certain requirements and restrictions related to that, but it's a much more streamlined process, especially if you're not actually planning to ever go to that state to practice, to continue to provide telehealth services. This telehealth registration pathway is actually what's being proposed in the Uniform Telehealth Act. So I mentioned this earlier, and this is where I think this particular piece of this act could have the most influence, is where it's basically enacting a telehealth registration system as an alternative to licensure. So it provides language within the act. You can go to that link and read it, that states can adopt, and it's very similar to what the other 7 states that I previously showed you have done, where if you're in good standing and you aren't going to build a bricks and mortar shop in that state, and you're going to pay this telehealth registration fee, then you can continue to provide telehealth in that state. So as of now, 4 states have introduced the Uniform Telehealth Act, and it's just a nice model piece of legislation so that we can try to get some more consistency across the states and how they regulate telehealth. Lastly, I'm sure we have a number of allied health professionals on the call. This is just a fantastic resource that HRSA supports for occupational therapists, physical therapists, psychologists, and social workers on how licensing works for them in certain states, across states with compacts. So if you're one of those practitioners or you're interested in this area, this is a great resource. So I'd like to now spend the next 5 minutes or so as we close thinking about other federal and state law as it relates to mitigating the digital divide. So, and one thing to highlight is so much of this talk and where we are with law and regulations is not what's happening on the medical healthcare side, right? Like things are just growing and booming in all kinds of different ways to approach providing healthcare outside of the hospital or clinic through virtual care. And how for regulation to keep up with that and be as innovative. And some of these next bills I'm going to show you, I think, are going more in that direction. So first off, there was this well-done study with the ONC, the Office for the National Coordinator for Health Information Technology. It was just published this last month in March. And typically when you see the biggest barriers to providing telehealth, it tends to be around licensure, reimbursement, the legal issues. But this study cited that one of the biggest issues, according to providers, was actually low digital literacy, the difficulty that patients had in using their equipment to get online, to access the patient portal, to connect with the provider. So now there's legislation at the federal and state level that I think tries to address this gap so that you can have telehealth appointments that can be more high quality and cost effective. So certain groups are disproportionately impacted by low digital literacy, and I've highlighted them here: lower socioeconomic, older adults, those in rural areas, those with limited English proficiency. And then we have the federal legislation, the Infrastructure Investment and Jobs Act, where billions of dollars to invest in digital literacy. There's this fantastic article in the New England Journal of Medicine called Digital Inclusion as Healthcare, where it identifies some of the ways in which healthcare organizations can begin to address digital literacy from a federal level. And I also want to just flag my colleague Janet Major, who talked at length about these issues and when to follow if you're interested in this area. But then what's happening at the state side, and there's been more and more bills like this. This is a recent one out of Massachusetts that's called an Act Relative to Telehealth and Digital Equity for Patients, where they're requiring payers that work with the state employees to have a digital health literacy screening program. And this would include things like identify those that may have low digital health literacy, provide all materials in multiple languages, and just be really proactive with how they're trying to address this issue, so that patients can have, so that the visits will go better and they can access their care with support. And the whole idea of digital health navigators, where somebody works with a patient to identify the right tools for them and help them troubleshoot any issues in getting to their appointments online. And very importantly, the role of librarians and then trusted community centers in this space. So this is a great infographic, and the only problem with it is that it doesn't include libraries, but it shows all the different ways that telehealth is providing for care outside the hospital, and that certainly is a trend going forward. It's at the federal and state level being supported by requirements to funding. It's certainly a space to watch. The other major one is the acute hospital at home care program. So this started in November of 2020 and just has boomed across the country, where now over 277 hospitals and thousands of patients have received care inpatient services in their home through this waiver with CMS. And this program has continued and is part of the Consolidated Appropriations Act to continue to the end of 2024, but just shows you another way that care is continuing to expand in the home, and what may be ahead in terms of looking at how virtual care is regulated and what may become permanent after the Consolidated Appropriations Act ends, or after the extension ends in 2024. And part of the reason it may become permanent is because there's been really great data showing the benefits of this option, particularly among older adults. This was an article this past November in the New York Times, just showing the preference, and also just what can happen to older adults when they go in and out of the hospital, to a skilled nursing facility or in rehab and back forward to emergency departments, and how, if they could just stay at home and recover there, what this could mean in terms of their ultimate care. So I think the more data we have to show the quality patient outcomes related to receiving care in the home, the greater likelihood that this could become permanent going forward. And I just want to kind of stress at the end, this is an area that I think about quite a bit and always happy to chat about it. There's just such a need for how we can better equip older adults and their caregivers with technology, virtual care, telehealth. There is enormous demand to not go and receive care in a nursing home, but to age in place. It's now over a 3-year wait for Medicaid eligible adults across the country to receive care in their home and not go to a nursing home. And while they're waiting, they are without care, they're on wait lists. And those are for Medicaid eligible older adults. And so, many Americans are struggling in this area, unpaid family caregivers. And I think the biggest demographic trend is that, currently we're at 7-to-1 ratio of working age adults to seniors. And by 2050, it will be a 3-to-1. So a need to think about more creative ways to allow for virtual care options outside of the hospital to support aging in place is just critical, which is above and beyond the public health emergency, but I think something to think about when we think about what flexibilities can be made permanent going forward. So thank you for your time. I'm now going to turn it back to Melanie.
Thank you, everybody, for putting the questions in the chat. We've got a lot of questions.
Wow.
On.
Oh my goodness.
So we'll try and get through quite a few of these. One question talks about what considerations might be being made for those who are deaf, hard of hearing, or deaf-blind. With telehealth, there's a lack of captioning and/or ASL interpretation, depending on platforms used to deliver services. How is effective communication being provided to ensure equitable telehealth experience? Do you have any information on that?
Oh, that's such a great question. I mean, I guess two thoughts, right? You have the individual provider approach you can't discriminate against your patients. You have to be able to provide the same service to all your patients, including those who may have a disability, such as a hearing impairment. So that that's a requirement. And the other issue I'd like to just flag for that is, even in that Massachusetts law that said multiple languages, it specifically said for a sign language option, and there's a lot of other state bills that do get into the issue of digital equity inclusion, which includes things like having multiple ways to provide telehealth for patients that have cognitive impairments, hearing or vision impairments, so that they can receive that care.
Great.
Wow.
We
These are a lot of
we got a lot of comments coming in right now. So this is being recorded. It will be on our website later. You'll be able to get the copies of the handouts and her links. All the links are active URL links. We've had some folks ask about, some of the links that you have mentioned. So when I do a thank you email to everybody, I will have all those active links in there as well, along with the URLs of where you can find the recording of this.
I'm so glad that's come up, because one goal of mine was for you to know where to go for more information. So I'm more than happy that we can share those links with you. And I also welcome anything that you'd like to share with me that I can help distribute. Yes,
we've actually had some folks put some information into the chat as well with regards to other resources. So we'll be going through that. We will be having, I've given you some questions on the certificates. Yes, there are certificates for attendance. I will send that information back out in an email to everybody as well. And if you have any questions, you can directly email me on that process. Let me go through some more here. Some other questions here. You mentioned RPM monitoring, RTM, patient explanation for data collection, but both cannot be reimbursed at the same time. Now, we did have a webinar about this particularly as well, which you can find on a previous webinar. But how would you bill? And he thinks it's a dealer's choice, whichever pays most. Is that RPM?
Yeah, it's really confusing. And I would definitely check out the webinar we have from our billing expert, but I know it's complicated with like the 16 days and the 3 days and how that relates to it. I do think that it makes sense to follow the money. So you would try to go with whichever will pay more, but also like from an access perspective, like what is your practice able to realistically do and to be consistent with the patient's needs? I didn't really get into, potential issues of fraud and abuse and billing and oversight, but because there is so much CMS data now, because so many more patients have accessed telehealth during the pandemic, the Department of Justice, the Office of Inspector General, they're going to be really looking at billing much more than they ever have been able to before, and be able to identify outliers. So something to think about to make sure that you're compliant with how your billing practices.
All right, thank you. Let's see, we've got just a few more minutes here. Let me see if I can find another question. Some providers are asking whether they can write separate prescriptions for the same drug instead of a refill to get around the 30-day requirement. Have you heard about that at all? I think it has to do with when you were talking about some of the regulated drugs.
Sure. So a separate prescription for a controlled substance?
Well, I'm not exactly sure we'll want to comment on that, because we don't want to go around the system.
Okay.
So we want to not share opinions. Sorry.
Right. No, I think I did, maybe to provide some clarity. One question I received was, does it have to be 30 days all at once? Could it be like 7 days and 7, like, could the 30 days be broken out different ways? And so this is helpful. It's up to 30 days, one refill for that particular, if it's a drug that's a controlled substance, prior to having an in-person visit.
All right, let me move on here. We've got a few questions with regards to that. Physicians licensed in multiple states, can they get a referral for a patient that is physically in another state and still treats them via telehealth? And I think you talked about some of the compacts that are set up for that, correct, in the legislation?
Yep. I would follow the compacts, and there's other, and like different states have their own, every state has their own board for different specialties, and some have this temporary practice laws, like maybe the patient's just temporarily in that state for I don't know, for different purposes. Like, so I would really guide you to go to the Center for Connected Health Policy, as I mentioned, and look up your particular state, because I can't speak to all 50 in the next minute.
Right. And we did put that link in the chat, and I will have that in the email out to everybody as well, so that you can have a link to that particular resource that she is talking about. Let's see here. Well, we've got just about a couple minutes left. Hold on a second here. Are you seeing any movement at the federal level to make telehealth flexibilities extended to the end of 2024 permanent for Medicare outside of behavioral health, which was made permanent?
Yeah, I think so. I think it's going to be very difficult to the geographic restrictions that were in place prior to the pandemic. That is something that we have all grown so accustomed to. And so you keep hearing this phrase, you can't put the genie back in the bottle, the telehealth back in the bottle. So I think that will be a difficult one to not continue to allow geographic flexibility. And then you can see with that Uniform Telehealth Act, it was very broad. I mean, it just had different locations in terms of how telehealth care is defined and delivered. So it got away from even this originating site language that still is being used. So that was very interesting. You know, as I mentioned, data, and whether anecdotal but also aggregate anonymous data, is very helpful in informing agencies in terms of guiding CMS and HHS in terms of what could become permanent after 2024. So there might be proposed rules. Like, it's never too early to start to think about how you can, for certain flexibilities that it's very much tied to your practice, for how to think about documenting that evidence going forward. Also writing it up, sharing the information. It's all very helpful, and can help this momentum to keeping some of these flexibilities permanent.
All right, and we are getting down to the end of our time. Thank you, everybody, for these questions, and I will forward them on to Tara, those that we haven't been able to address, that hopefully she can answer, and we can get those out individually.
I hope so.
You've got a lot
There's
of
a lot.
questions here. Yes, there is. And thank you, everybody, for joining us. And again, you'll see the evaluation that has popped up behind your screen when you joined us. Please go ahead and fill that out. And the code for today's session to your attendance for your CMEs is listed in that evaluation as well. So yes, thank you again, everybody that is putting the questions in. I'm going to copy the last few that have been coming in since we've been going over the list that Chris was helping me make here. So anyways, again, thank you, everybody, for joining us. And I will get the email out later this afternoon with all of the links and the information that's been shared. And we'll get some answers to questions a little bit later out to those who asked that we weren't able to get to. So any closing thoughts?
Keep in touch.
Right.
Yeah, absolutely. Keep in touch. We'll be doing more and more webinars. And we also welcome, topics that you'd like our team to address going forward. So this is definitely not a one-off.
Excellent. And it looks like somebody just asked about the evaluation link. I'm going to go ahead and just put that into the chat right at the moment right now. And you'll be able to link to that if you closed your window that was in the background. And here it is. All right. Thank you, everybody. So go ahead and click on that, and we look to hear from you. Look forward to hearing from everyone later. Thank you.
Take care. Thank you.
Bye.
Tara, thank you very much. Wonderful presentation.
Thank you. Take care.
Bye.
If you haven't grabbed that link for the evaluation, it's right there in the bottom of the chat.